seconds. Let me repeat. When action potential is being transmitted from the SA node to the AV node, it usually has a delay of 0.03 seconds. And even most importantly, after the action potential has reached the AV node, before it goes to the bundle of Is, it usually delays for another 0.09 seconds. That's very, very important. We're going to see how it usually looks like in the ECG. Then even intriguingly is that after the delay in the AV node for 0.09 seconds, before it goes, no, after the delay for 0.09 seconds, it will now be transmitted to the AV bundle. Again, it usually has a delay of 0.04 seconds. So the total delay of action potential before it goes to the bundle branch is usually 0.16 seconds if you add all of them. That is very, very important as far as the ECG is concerned. Kindly remember it. Now, I want us to remember the following, that this is the apex of the heart. You see where my cursor is moving? This is the apex of the heart. And here we have the base of the heart. That's very, very instrumental. So see what is happening. Action potential will come from the SA node, AV node, to the bundle branches, going all the way to the apex. Then after depolarizing the apex, it will be now going back to the base. You can see how it is moving. So this action potential is moving in this particular direction, like this, going down. Then first of all, it will depolarize the apex of the heart. Then after depolarizing the apex, it will now go towards the base. So I want us to remember that direction because it is going to be very important for you to understand how that is usually presented. Or someone is telling me, can we recap on the 0.16 seconds? Okay, let me recap. Now, from the SA node to the AV node, we know that action potential is being transmitted, right? So the time taken for that action potential to come from the SA node to the AV node is usually 0.03 seconds. Now, after that action potential has reached in the AV node, it usually delays for another 0.09 seconds before it goes to the AV bundle. Then now after going to the AV bundle again, it usually delays for 0.04 seconds. Get? So when you take the total time taken, it will be 0.03 plus 0.09 plus 0.04, which will give you a total of 0.16 seconds. So that is always the total delay of action potential before it goes to the bundle branch. It will be very important when you start talking about the ECG. Now, when you on your free time, go and actually confirm these internodal pathways. You have the anterior, the middle, and the posterior, and you have the Bachmans. But because you're not doing anatomy, I'm not going into that. Now, this is what I'm talking about. These are the delays that usually occur during action potential. You see, here we have the SA node. Then from the SA node to the AV node, you can see here we have 0.03 seconds. Basically, that is a delay. Then after reaching the AV bundle, we can see that we are delaying for 0.09 seconds. Then at the AV bundle, you're delaying for 0.04 seconds. You see, that is what I want us to remember for this particular discussion. That from the SA node to the AV node, we are going to have a delay of 0.03 seconds. In the AV node, we usually have a delay of 0.04 seconds. Kindly ignore 0.12. I don't know where it's coming from. Oh, this 0.12 is basically an addition of 0.03 plus 0.09, giving you 0.12. Then again, at the AV bundle, we usually have a delay of 0.04, so a total of 0.16. That is basically the delay. So this slide is trying to show you the delays that we have in the heart. Before I continue, it's really important for us to understand that the atrium and the ventricle are usually separated by an atrioventricular fibrous tissue or fibrous band, meaning that action potential must pass through the conduction system of the heart before it goes to the ventricle, because the atrial muscle fibers are not continuous with the ventricular muscle fibers. So the atrial muscular fibers cannot excite the ventricular muscle fibers. I hope you're getting the point. That's why we need to have the atrioventricular fibrous tissue. This will come in exam. You might be asked the question, why is it important? Why is it relevant? It is important because for the normal pumping of heart in the blood, the atrium must contract first, then the ventricle contracts second. So this atrioventricular fibrous band usually prevents the heart from contracting as a whole, in that it will make the atrium to be the atrium and the ventricle to be the ventricle by that separation. So again, that is very, very important for that mechanistic pumping of the heart. Now, we are now studying the ECG waves. This is now very important. Now, when you look at your heart, we have the atrium, we have the ventricle. First of all, the ventricles usually contract, the atrium usually contract. So the P wave in the ECG is usually representing the contraction of your heart, of your atrium, sorry. So the contraction of the atrium in the ECG is what usually brings about the P wave. So when you're going to do your further studies, guys, I actually recommend that you go and look for the normal duration of the P wave. Oh, someone is telling me, please repeat the point of the heart not contracting as a whole. Okay, let me repeat before I continue. So what I was saying is that, look at the diagram that you have up here. We have the atrioventricular fibrous band. So this atrioventricular fibrous band is usually important for two particular reasons. Number one, it prevents the heart from contracting as a unit, as one unit, because blood is being pumped from the atrium to the ventricle, you see? So in real sense, we need to contract the atrium first to push all the blood into the ventricle. Then now we contract the ventricle to push blood to the systemic circulation or the pulmonary circulation. Now that's why the atrioventricular fibrous band is very important. Why? Because it will kind of like separate the atrium from the ventricle. So the atrium must contract first, then the ventricle contracts second. The second reason is that this band is very important to ensure that only the conduction system of the heart is responsible for the contraction of the ventricle. In short, let me come back. That atrioventricular band that I've talked about is very important to ensure that the ventricle are just going to contract based on the action potential that they receive from the SA node. You see? Like, that is it. To ensure that the ventricles are contracting, not because of their own capability, but because of the conduction system of the heart that I've been talking about. Now let us go to the ECG waves quickly because of time. Now in the ECG wave, we always have the P wave. The P wave is chiefly responsible for ventricular or atrial contraction. Then after that, guys, we've said that once the SA node has taken the impulse to the AV node, the impulse is usually delayed in the AV node for like 0.09 seconds. And that is why after the atrium has contracted, we now have a flat line. This flat line is called isoelectric line, where the voltage is 0 millivolt. What does it mean? It means that there's no electrical activity occurring in your heart. And the reason is simple. The reason is because there's a delay occurring at the AV bundle. Like at the AV bundle, you have a delay, so there's no action potential being transmitted in your cardiac tissue. And that is why we have a flat line. Let me repeat, this is very, very important. After the atrial contraction, where we have the P wave, we go back to the isoelectric line, the 0 millivolt. And the reason for this is because the action potential is at your AV node, and there's a delay occurring at the AV node of 0.09 seconds. And that's why we are going back to the isoelectric line, because there's no action potential activity within a heart. Now let us continue. Now we have the Q wave. The Q wave is usually the septal depolarization. Let me see. Let us talk about it. I hope you can see the diagram that I'm projecting for the heart. Now, action potential came from the SA node. It went to the AV node. Then notice from the AV node, we are going to the septum before you go to the ventricles. So when you're going through the septum, the action potential is doing what? Depolarizing your septum. And that's why you have the Q wave. The Q wave is because the action potential is depolarizing the septum of your heart. That's why we have it. Now, look, we have also the R wave. The R wave is one of the largest wave in your heart. You can see the R wave going up. So what about the R wave? Now, the R wave is for your apex ventricular contraction. And that's why when I started, I was telling you that action potential will go to the apex, then it goes to the base. You see? Now, after action potential has depolarized the ventricle septum, it will go to the apex. Now, at the apex, we'll have the R wave. So the R wave is for the ventricular contraction at the apex. I hope you're okay up to that point. After depolarizing the apex, action potential will follow the Purkinje fibers towards the base. So as it is moving towards the base, we'll have depolarization of the base. And that's where we have the S wave. So the S wave is for ventricular depolarization, but at the basal region. So remember, the QRS complex is for the ventricular depolarization, but the Q wave is for the septal ventricular depolarization. The R wave is for the apical ventricular depolarization, while the S wave is for the basal ventricular depolarization. So you should actually go to Ninjanad and understand why we have a positive deflection here and why we have a negative deflection here. But when you go for the practical, I think it will be clarified in that practical. It will be explained why we have a positive deflection, why P wave is going up and Q wave is going down. But for our discussion today. If I go into that, I'm going to consume a lot of time. Now let us continue. After the S wave, we usually go to this particular point here. You see, it's actually an isoelectric line. Okay, so let me continue. Now, after we have depolarized the ventricles, we now come back to this S wave, and after S wave, you can see that we're going back to the isoelectric line. The thing is simple. After I have depolarized your heart, it will take some time before I repolarize your heart. Let me repeat. After depolarization, there'll be no action potential within your heart. There will be no action potential because I've now depolarized it. Now I need to wait for some time before I repolarize it again. So before I repolarize it, I usually go back to my isoelectric line, meaning that there's no electrical activity within your heart before I go to repolarization. And that's why between the S wave here, we have this flat point. That's very, very important. Now, after some time, now your heart will be depolarizing. Your ventricles will be depolarizing, okay? So when your ventricles are depolarizing, now we go to the T wave. T wave is for ventricular depolarization. T wave is for ventricular repolarization, sorry. T wave is for ventricular repolarization. Kindly remember that. It will be set in your exam. Now let us continue. Usually in the ECG, you have another important wave called the U wave, though it is not found in every ECG. Now, when you have a U wave in the ECG, what are you supposed to look at? You're supposed to look at the size of the U wave. So if the U wave is small, that is a normal U wave. Like in case the U wave occurs in your heart, it will be a normal U wave if it is small. But in case it's a very huge U wave, then it is pathologic. So the reasons why the U wave usually develops in a normal ECG has not been well elucidated up to this particular moment I'm speaking. But there are so many theories revolving around how it is usually generated. So kindly, we are going to look at some of the reasons, but take your time to go through it. But remember, if you have a prominent U wave in your heart, it means that you have a problem. Okay. Now, before we continue, I want us to talk about some very important concept that's going to come in your exam. We have something called the RR interval. But before I continue, this is one ECG. Okay, atrial depolarization, ventricular depolarization. Then this one is ventricular repolarization. Before I continue, you notice that in this ECG, we don't have atrial repolarization. We only have atrial depolarization. The reason is simple. At the same time, when the atria is undergoing repolarization, your ventricle usually depolarizes. So in other terms, atrial repolarization usually coincides with ventricular depolarization. So because the QRS complex is very big, in a normal ECG, we can't see the atrial repolarization wave because it has been obscured by the larger QRS complex. So ideally, it's supposed to be in this particular diagram, but because it is coinciding with the QRS complex, we can't see it. It has been obscured. That's why we can't see it. It is not there. Okay. Now, after this ECG, after this one ECG, you're going to go to the next one where we just start with, this one is T wave, then you go to the P wave, then you go to the QRS, then again T wave. You know, that procedure will continue up to a given particular point where we stop the ECG from running. But what are we supposed to know? We have something called the RR interval. The RR interval is the distance between the R waves. The RR interval is the distance between the waves. And why is it important? The RR interval usually coincides to one heartbeat. Let me repeat. The RR interval usually coincides with one heartbeat. And you're going to understand why is it very crucial for you to understand this, because we're going to calculate heart rates in a few, and we're going to understand why it's so important like that. Then before I continue, you have something called an ST segment, and interval. So the difference between a segment and an interval is that a segment contains an isoelectric line plus a wave, while an interval only contains a flat line. No, sorry, it's the other way around. I'm just confused. A segment will just contain a straight line, while an interval will contain a wave and a line. Sorry for that. Let me explain. So in an exam, if you have been told the PQ interval, the PQ interval will start from this P wave where it's beginning, to this particular point. That is the PQ interval. An interval contains a line and a wave, but a segment only contains a line. So when I tell you a PR, usually it can be a PR interval or a PQ interval. It's the same thing. Remember that. So when I tell you a PR interval, I'm telling you to start from the beginning of the P wave, this particular end of this isoelectric line here. But when I tell you the PR segment, I'm telling you to only focus on the isoelectric line in between the P and the R wave. That is the difference between an interval and a segment. Now, before I continue, I want to talk about a very important thing that you're supposed to go and look at. When you're studying, go and check the normal time for the QRS complex. Usually it's 0.08 seconds to 0.12 seconds. That is the normal time for the QRS complex. Why is it important? Maybe someone can just comment in the chat box. If the QRS complex time is elongated, what do you think is happening to your heart? And where do you have the problem? Maybe someone can just unmute, or maybe you can, it's a discussion. It's a discussion. Maybe someone can type in the chat, whether direct to me or maybe to the entire group, or you can just unmute. Let me repeat my question. You have said that the normal QRS complex time is 0.08 seconds to 0.12. What if you have a patient who has a QRS complex of, let's say, 0.25 seconds? Where do you think you have the problem in the heart? And what might be the problem? Someone has said it will eject too much blood. Any other response? If the QRS complex is elongated, which part of your heart do you have a problem first? Which part do you have? Is it the septum, the ventricles? You know, where do you have the problem? Amazing, the ventricles. So when the QRS complex is elongated, it means that the patient has a problem with ventricular depolarization, right? And because it has been elongated, it means that your ventricles is taking a lot of time to do what? To depolarize. So you go and look at every condition of the heart that will cause the ventricles to take a lot of time to depolarize. One of a very good example is ventricular hypertrophy. The second one can be the left bundle branch block and the right bundle branch block. We're going to talk about them, don't worry. That's why it's really important for you to understand the QRS complex. Oh, before I continue, I forgot to mention a very important concept. Let me come back here. Sorry, guys, for that. Now, I told you guys that the SA node is the pacemaker of the cell. But I want us to understand this concept, that in any event, your SA node will fail and stop functioning. In any event, your SA node will stop functioning. The AV node will become the pacemaker of your heart. So this concept is what we call ectopic pacemaker. So let me type it in the chat. What we call ectopic pacemakers. Ectopic pacemakers, that can come in your exams. Let me repeat. In a normal heart, we know that the SA node is usually the pacemaker of the heart. But in case it fails, God designed in such a way that if the SA node fails, the AV node will now develop and become the pacemaker of your heart. That's very, very interesting. And even most intriguing is the fact that when your AV node and the SA node fail, the Purkinje fibers are going to be your pacemakers of your heart. So you can't die easily. Like your heart has a lot of backup. The SA node will fail, the AV node will take over. The AV node fails, the Purkinje fibers take over. So there's no way you're going to die. But the problem is that the SA node is the most efficient one in terms of pumping or in terms of the heart rate. For example, the SA node will bring a heart rate of 60 to 100 beats per minute if it is the pacemaker. But the AV node can only bring it to around, I think, 15 or 35 there to 40 to 60. I think it is 35 to 60. You can go and confirm the value. But the Purkinje fibers can bring the heart rate to around maybe, I think, 15 to 30. I'm not so sure about the values. You can go and confirm. So this concept is called ectopic pacemakers. Very, very important in that the SA node fails, the AV node takes over as a pacemaker. The AV node fails, your Purkinje fibers take over as the pacemaker of your heart. But this is very detrimental to the patient, to the patient. Why? Because your SA node is very important for priming your heart. How can I put it? There's something called the override mechanism of your heart. Doc will ask you this question during the practical. I have a question. Why do you think that even though the AV node can be a pacemaker of the heart, it doesn't, in a normal condition, it doesn't behave like a pacemaker? What do you think might be the reason? Like your AV node, your Purkinje fibers can be pacemakers of your heart. But in a normal condition, it is the S node that is the pacemaker, and the AV node and the Purkinje fibers cannot be pacemakers. What can be the possible reason? Maybe someone can unmute or just type in the chat box. It's a discussion. Don't fear. We are here to learn, all of us. Someone has talked about efficiency. We are almost there. There's something so as to facilitate conduction. Now, let me give you a simple analogy that usually happens in your heart. Imagine you are running 100-meter race, and someone is pushing you at your back. Someone is pushing you to run. And all of a sudden, this person stops pushing you. What do you think is going to happen? You are running, and someone is pushing you. So when this person is pushing you, you are moving faster. Then all of a sudden, this person stops pushing you. What do you think is going to happen? Are you going to slow down fast, or you're going to keep on running fast? What do you think is going to happen? Yeah, correct order. You're going to slow fast a bit before you realize, oh, this person is not pushing me. I need to catch up. So we have something called overriding mechanism of your heart. In as much as the AV and the Purkinje fibers can be the pacemakers of your heart, but they don't always behave like that because they're being overridden by the SA node. So because the SA node is actually overriding them at a very huge velocity, it is kind of like slowing them a little bit. You get? And that's why now for ectopic pacemakers, if I fail the SA node, now the AV node will actually realize that, oh, the SA node is not functioning. So I'm not being overridden. Now I need to take over the role and start running on my own. That's the concept of the ectopic pacemakers. Why is that important? There's a condition called Stokes-Adams syndrome. Let me type it in the chat box. I know it's quite a lot, but we need to move. Stokes-Adams syndrome. I want us to understand this condition before we continue because it can come in your exam. Now, what about it? We have said that in your normal heart, the SA node usually overrides the AV node and the Purkinje fibers. And that is why even though the AV node and the Purkinje fibers can be pacemakers, they are usually not pacemakers because there's a very huge force somewhere in the SA node trying to override them, making them to run. But in case the SA node fails, it will take the AV node and the Purkinje fibers some time to realize, oh, the SA node is not functioning. The same way Ora said that when someone is pushing you and this person all of a sudden stops pushing, you're going to slow a little bit before you now catch up with the pace. The same thing is going to happen in your heart. I'm overriding your AV node. If I stop overriding the AV node, the AV node will slow down for some seconds before it realizes I need now to work. Then now it will catch over. Now, why is this thing detrimental to your health? Before the AV node takes over, or before the Purkinje fibers take over, the heart usually slows down to around 5 to 20 seconds. For about 5 to 20 seconds, your heart rate usually falls detrimentally low. So this can lead to something called syncope. The patient might fail. Why? Because your brain is very important and your brain depends on oxygen. Imagine if you cut the blood supply to the brain for only 5 seconds, you're going to be unconscious. So imagine in the Stokes-Adams syndrome, I've failed the SA node. The AV node is taking over, but it is taking some time before it takes over. So before it takes over, it means that the heart pumping will be very low, that a very slow amount of blood will be reaching your brain tissue. And that's why these patients usually fail. They usually undergo fainting, syncope, in Stokes-Adams syndrome. Let me ask you guys another question. In case I have an ectopic pacemaker where the AV node is functioning as the pacemaker of the heart, which wave do you think won't be here in the ECG? Let me repeat. In case a patient has an ectopic pacemaker where the AV node is now taking over the role, which wave do you think won't be in the ECG between P, Q, R, S, and T? Which one won't be in the ECG? An ectopic pacemaker where the AV node is the pacemaker. Amazing. Amazing. The P wave. Yeah, it's the P wave because the SA node has failed. It cannot contract the atrium. It can't. So there's no P wave in a Stokes-Adams, no, in an ectopic pacemaker where the AV node, the SA node has failed. So the P wave won't be there. Now, that's how we usually answer these ECG questions. Let us continue because of time. I don't want to take a lot of time. Yep. So for this one, I've actually talked about them. For the U wave, you see, the exact cause of the U wave has not been found, but it's believed to be due to repolarization of the Purkinje fibers or other parts of the ventricle. So in your free time, you can just go and check on the U wave. I'm not going to dwell so much on it. Now, this video here is basically from Ninja Nerd. For those people who have not taken some time to go and look at that genius, kindly take your time to go and look at that video, because it's going to tell you why the P wave usually goes up, the Q wave usually goes down, and things like those. However, if I've been in the ECG practical this coming week, we'll actually discuss about how that usually happens. And maybe if you have a question after this session, maybe you just want to understand how that usually happens, feel free to reach out to my inbox. We can have a very short discussion before we continue. But because of time, I want to continue. Now, we go to the ECG leads. Now, from physics, we know that your body is a good conductor of electricity. So imagine a situation whereby I'm electrocuting a friend of mine. Maybe I'm electrocuting Christian Aura, God forbid though. I'm electrocuting Aura. Then someone like Violet comes and holds Aura. What do you think is going to happen? Violet will also be electrocuted. So meaning that your body is a good conductor of electricity. In your body, we have the nervous system where we have the nerves. Remember, your nerves are basically like electric wires, and your action potential are basically like current. So as action potential is being generated and being transmitted throughout your nerves, because your body is a good conductor of electricity, they can actually be transmitted to the surface of the skin. So that was the basis of the ECG, in that when I take a lead and I put it on the surface of your skin, it can register an action potential or a voltage difference, because your body is a good conductor of electricity and it can conduct action potential. So these three leads have been developed over time. And actually, we have something called Einthoven, who won a Nobel Prize for this particular concept we're talking about. We are going to see what actually he did. Now, in the ECG practical, it will be a curse for you to exit the lab without understanding the standard bipolar limb leads, the augmented unipolar leads, and the chest leads. Before I continue, I want to clarify something here that might come in the exam. We have 12 leads in the ECG. We have standard bipolar leads, which are usually 3. We have the augmented unipolar leads, which are usually 3. And we have the precordial leads, which are usually 6. So they total to 12. Even most importantly is that we have 6 limb leads and 6 chest leads. You see, the standard bipolar limb lead is a limb lead. The augmented unipolar limb lead is also a limb lead. So 3 plus 3 will give you 6. This will come in the exam. So remember, we have a total of 6 limb leads, and you have also 6 precordial chest leads. That's very, very important for your exams. Even most importantly, we have something called unipolar limb lead and bipolar limb lead. We only have 3 bipolar limb leads in the ECG. The standard bipolar limb leads are the only bipolar limb leads. You're going to understand them better, don't worry. Then the augmented and the chest lead are usually unipolar. So we have 9 unipolar limb leads. Let us continue. So we start with the bipolar limb leads. The question then becomes, how do we connect them? So this is your patient, and we want to connect the standard bipolar limb leads in this patient. So how are we going to do that? That's the most important question. So you can see we have a patient, and we have leads that have been connected to this patient. Guys, this is going to come in your exam, so you need to take it seriously. So for the standard bipolar limb leads, we always use 3 points in your body. We use your right hand, your left hand, and your left foot. Those are the connections. So for lead 1 of the standard bipolar limb lead, we usually make a connection between the left hand and the right hand. Let me repeat that. For standard bipolar limb lead 1, the connection is made between the right hand and the left hand. So look at this patient. We have this wire connecting this right hand and this one to left hand. And we're measuring the potential difference between this left hand and right hand. That is lead 1. Before I continue, you need to remember that for lead 1, the left hand is usually the positive terminal, while the right hand is the negative terminal. Let me repeat. I know it's quite a mouthful. For lead 1, you're making a connection between the right hand and the left hand. And even in so doing, in so doing, the right hand for lead 1 is usually the negative terminal, while the left hand is usually the positive terminal. Then now we are going to register the potential differences between the left and the right hand. Why are we doing this? Because when action potential is being generated by your cardiac tissue, it can be transmitted to your body, even to your hands. And that's why I can actually register some current when I put a lead here, because action potential is being conducted by your body. What about for lead 2? Lead 2 is usually connected between your right hand and your left foot. So for lead 2, your left foot will be the positive terminal, while your right hand will be the negative terminal. So you see what is happening? We are connecting this wire here to this voltage reader. Then again, you're connecting this wire here. But this one is the positive terminal, and this is the negative terminal. You can even see from our voltmeter. This one is positive, this one is negative. That is for lead 2. Remember, for lead 2, the positive is the left foot, the negative is the right foot, the right hand. Then for lead 3, the positive is the left foot, while the negative is the left hand. That is how we usually connect them. So remember, the left hand can either be positive or negative, depending on the lead you're using. If you're using lead 1, it will be positive, but if you're using lead 3, it will be negative. I hope you're okay up to that point. Let us continue. So this is now what we call the Einthoven triangle. See, in this particular scenario here, I can draw this triangle. Actually, this person is not supposed to be in this particular position, but you can see you can have this triangle here. You can have this triangle here. Let me try to show you guys. I hope my camera is visible. Don't mind the background. Where you're working in areas where you need to be dirty. So this diagram is supposed to be like this. You see the way I've placed my arms. It's supposed to be like this, so that I put here, I connect here lead 1, lead 1. So lead 1 should be from here to here. That's lead 1. Then lead 3 should be here to my left foot. Okay, you can't see my left foot. It should be here to my left foot. Well, okay. Hello, am I audible? Oh, okay. Paul, I think I'm back. So let me continue. Now, when I'm connecting the ECG from this diagram that I've projected, this patient is like this. But usually, for us to explain it better for the student, you're supposed to be this particular way. See, I've forgotten anatomy. This was called, I don't know, abduction or Sakamoto. I can't remember. Okay. Now, what usually happens where we're in this position, lead 1 will be connected between your left hand, and your right hand. You see? And the negative terminal will be your right hand, positive will be the left hand. You see? So when I connect a wire from ear to ear, then I connect it to my right foot, I can draw a triangle. You can see that triangle. I can draw that triangle like this to your foot. Now, when I take that triangle and I bring it to your heart, I usually form something called the Einthoven triangle. And that's why when you look at here, we have this Einthoven triangle. I hope you can see it. This is called the Einthoven triangle, where basically, look at, let me focus on this other diagram. Now look at it. This one here is lead 1, where my cursor is moving lead 1. And in this lead 1, you have the left arm and the right arm, and here we have the left foot, or the left leg. Now, between the right hand and the left hand, for lead 1, the right hand is what? Negative, while the left hand is what? Positive, for lead 1. For lead 2, the right arm is negative, the left leg is positive. And finally, for lead 3, the left leg is positive, while the left arm is what? Negative. And that's why I was telling you that the left arm can be negative depending on the lead you're using. So that if at all you're using, if you're using lead 1, it will be positive. If you're using lead 2, it will be negative. Now, this is what you call the Einthoven triangle. And sorry for that. And this is going to be very important when you start discussing the main electrical axis of your heart. Let us continue. Now, guys, this is what we call the Einthoven rule. This will come in the exam. The Einthoven rule usually states that the summation of lead 2 is equals to, no, the Einthoven rule usually states that lead 2 is equal to the summation of lead 1 and the summation of lead 3. Now, let us focus on the ECG that we have to our right. Don't be shocked so much about the presentation. We're going to dissect. you guys dissected anatomy, so we're going to dissect physiology today. Now, look at lead 1, lead 2, and lead 3. Notice which one is taller between the three. It is lead 2, right? So because lead 2 is taller, lead 2 is equals to lead 1 plus lead 3. You can actually look at it. Look at lead 1 and lead 3. If I actually add them, they can actually give me lead 2. That is what we call the Einthoven rule. And anytime you are going to run an ECG in the lab, in the practical, you'll see it with your own eyes that lead 2 is equals to lead 1 plus lead 3. That is what we call the Einthoven rule. So in an exam, if you have been told the voltage for lead 1 was 5, for lead 3 was 10, what is for lead 2? You can use the Einthoven rule to do that calculation. Let's continue. Now you can see from this ECG, we have the P wave, we have the QRS complex, we have the T wave, then again the P. For all of them, you can actually understand, you can actually see them. That's very, very important. Now, before I continue, let me ask you guys a question. Between lead 1, lead 2, and lead 3, which one has been aligned according to the direction of action potential flow in your heart? Let me repeat my question. Between lead 1, lead 2, and lead 3, which one has been aligned according to the action potential flow in your heart? Which one? Anyone in the chat box? Amazing, lead 2. Ah, that's great, lead 2. Let me try to show those people who are not actually seeing it. So look at my chest. Don't admire my big chest. I'm joking though. So you see, when I'm in this position, if I want to connect lead 2, I'm going to take it from my right hand to my left foot. But yeah. You see? And when you look at the normal architecture of your heart, it usually comes like this. From here, we have the base, then going like this, you have the apex. Of course, this is my left side. So you can see that lead 2 again is coming from the right hand to the left foot. So basically, they are going in the same direction, going down. I hope you're getting the concept. Let me repeat. So when I am like this, I'll put my lead here and in my left foot for lead 2. So it will be running from this particular direction towards my left foot. I hope you're getting the point. When you look at my heart again, it is usually aligned where the base is somewhere here, but the apex is going all the way to the 5th intercostal space mid-clavicular line. So you can see that in a way, it is following the flow of what? Of that lead 2. I want you to understand that because that's very, very important. And you're going to use it to understand many concepts about the ECG. So let me continue. Okay, so before I continue, someone is really being giggled. Like, Roy, why can't you tell us why the PO is going up and I don't know what is going down? So at this particular point, we have agreed that this diagram won't really give me what I want, guys. Or someone is telling me to please repeat. I don't mind. So let me, okay, so what I'm saying is that, look at my position. Here we have your right hand and here you have your left hand. So lead 2 is usually connected from your right hand to your left foot. So it's basically coming in this direction, going down. You get? And your heart again is oriented in this particular way where the base is here and the apex in this particular direction. So your heart is going like this. So like all of them are following the same direction. And that's why lead 2 is usually used as one of the most important marker when you're doing the ECG. Let me continue. I don't want to waste a lot of time. Now, I hope you guys have understood the Einthoven rule. That's very, very interesting. Now, I want us to talk about determining the mean electrical axis of your heart. Now, this is going to come in your exam. This is very, very important. So before you continue, the question then becomes, what do we mean by the mean electrical axis of the heart? What do we mean by that? What we mean is that when you are, let me come back to this diagram up here. The mean electrical axis of your heart usually follows the direction of action potential flow. In that, for this particular diagram that I'm projecting here, because action potential is being carried from the SN node, AV node to the Purkinje fibers, the mean electrical axis of your heart is going to follow this particular direction. So like, in short, the mean electrical axis of your heart usually follows the direction of action potential, which is from the SN node to the AV node. That is the mean electrical axis of your heart. Now, let us continue. Why is it important? We're going to understand why it is important. So in case I change your heart position, let me also show you guys this one. Now, so your heart is somewhere here. I don't know what I can use. I think I can use this bottle here. So assuming this is your heart, it's always oriented like this. So because action potential is flowing from this particular point going all the way down, your mean electrical axis will go in this particular direction. You get. Imagine a situation whereby a patient has been born with dextrocardia, and dextrocardia, your heart is in the right side. So in fact, the mean electrical axis can even go up. So basically, the mean electrical axis usually follows the direction of your heart and the apex. In that, if it's oriented like this, your mean electrical axis again is going to follow this particular direction. You get? If your heart is vertical, the mean electrical axis is going to go down. If your heart turns in this particular direction, your mean electrical axis is going to follow that direction. So the mean electrical axis usually follows the direction of your heart always. Okay? So the mean electrical axis usually changes physiologically depending on, number one, deep expiration. I won't explain that, but I want to talk about the obese people. If you know you are obese in this class, I'm not talking in a very demeaning way. If I'm doing that, kindly forgive me. But what is happening is this. In a normal person like me, look at my heart. I expect my heart to be in this particular direction for a normal person like who is not obese. And a person who is not slender, you know, someone who's at the middle. Your mean electrical axis is supposed to be in this particular direction. But if you're obese, because we have a lot of visceral fat in your abdomen, it will kind of like push your diaphragm up. So as it is pushing your diaphragm up, what do you think will happen? Your heart will be compressed like this going up. Let me repeat. For obese people or people who are very fat, we have a lot of visceral fat within their viscera. So it will push the diaphragm up. And the diaphragm, because the diaphragm and the heart are closely together, now that movement will cause the heart to also be pushed up. So usually in patients who are obese, their mean electrical axis will be more to the left. You get, because the heart is being pushed more to the left, you see, by the fat. But if you are short, no, if you are slank and you're very tall, you have a very narrow chest, your heart will be able to fall because there's no fat even compressing it. So for people who are very slender and slim, their mean electrical axis is usually more to this particular direction. That's very, very important. That's physiological. Okay, let me continue. Oops, sorry for that. We are about to finish our class today. Don't worry. Kindly just take arts now. So which triangle was this one? The Einthoven triangle. So this triangle is in your manual. In an exam situation, again, it can be brought. So how do you determine the mean electrical axis of your heart? Before I continue, the normal range for the mean electrical axis of your heart is negative 30 to 90. But some books can talk about a value of 110. Let me show you guys. Now, imagine this is your patient. I can do what? I can draw this quadrant. I can draw this quadrant like this and like this. Of course, this is your chest cavity. So this one here will be, if I draw it, this will be the horizontal line for lead one. Get the point. This one is the horizontal line for lead one. Then this one is for lead three and lead two. That was our triangle. Now, I can draw a circle around this triangle of mine, as you can see from the, don't focus so much on my video, also focus on the screen. You can see you have the triangle, then you have the circle that I've drawn. So I have that triangle, then I can draw a circle around it, as you can see, right? Now, that is a procedure that you'll be doing in an exam. If you have been given a triangle, draw a circle around that triangle from mathematics. I hope you can do that. Now, this one here is lead one. You can see where I'm moving my cursor on the screen. This one is lead one. Then this one is lead three, as you can see, lead three. Then this one is lead two. Okay. So for a normal person, your apex is supposed to be in this particular direction. This is very important, so kindly be keen. In a normal person, your heart is supposed to be in this particular orientation where we have the apex here. You get? But we are different. Someone can be very fat, but you are normal. So the range for the mean electrical axis of your heart is usually negative 30 to 90. So that if a patient has 90, has 75, has -20, or has even -25, that person is normal. You have a normal mean electrical axis. But if I go away from that range of negative, if I go away from that range of -30 to 90, now you're going to be abnormal. Okay, so before I come back to this diagram, let me show you what I'm talking about. So look at the diagram that I'm trying to project. Now this is your heart, you can see. It has been divided into 4 quadrants. You have the normal mean electrical axis of the heart from -30 to 90. That is the normal. So if you have a patient who has -25 to -89, that patient has a normal mean electrical axis. But in case the patient now has an angle that is past this range, the patient will have a defect. Okay? Now, if the patient's mean electrical axis between +90 and +180, that is called the right axis deviation. And we're going to see which conditions can lead to right axis deviation. On the other hand, if the patient has an angle of between -30 to 90, which is away from -30 to 90, which is our normal physiological range, then the patient has a left axis deviation. And finally, if you are between -90 to 180, then you have an extreme axis deviation. So if a patient has been born with dextrocardia, the patient will have extreme axis deviation. Dextrocardia as a congenital anomaly usually causes extreme axis deviation, while left ventricular hypertrophy will cause left axis deviation. Right ventricular hypertrophy will cause right axis deviation. And even most importantly, the left bundle branch block will cause left axis deviation, while the right bundle branch block will cause the right axis deviation. So basically, this is how we're supposed to interpret the mean electrical axis of your heart. In that, you draw the quadrant between -30 to 90, normal, from -30 to -90, left axis deviation, from +90 to +180, right axis deviation, and finally, from -90 to 180, +180, we have the extreme axis deviation. Then remember, extreme axis deviation, congenital anomaly like dextrocardia, left axis deviation, left ventricular hypertrophy, left bundle branch block, right axis deviation, right ventricular hypertrophy, and the right bundle branch block. That can come in your exam. So that's very, very, very important. Let us continue. Or before I continue, guys, I have a question. In case I block the bundle branch block, let me come here so that you can see. Focus on the diagram that I'm projecting. In case I block the left bundle branch, basically that's what we call the left bundle branch block. When I block the left bundle branch, I call it the left bundle branch block. So when I block the left bundle branch block, what do you think will happen to the QRS complex? Will it be elongated, or it will be narrow, or it will be normal? Maybe someone can give us some enlightenment on the chat box. Will it be elongated, narrow, or normal if I block the left bundle branch block? Anyone? Amazing. It will be elongated. Let me explain why. Because remember, for me to depolarize your ventricle, action potential must go through the bundle branch. So in case I block one bundle branch, I'll be delaying. It's like I'll be blocking that pathway for action potential flow. So it will take some time before the ventricles does what? Contract. So basically, left bundle branch block or even right bundle branch block usually causes an elongated QRS complex because of delay that occurs at the septum during action potential transmission via the bundle branches. So in a free time, you can go and look at the following. You have something called atrioventricular block, type 1, type 2. And for type 2, you have something called Mobitz type 1 and Mobitz type 2. They are very, very important. But I don't think if they come in your exam, but maybe for you to be well-grounded, you can just go and look at them. They'll be very important even later on. Now, let us continue very fast. So let us go on how to determine the mean electrical axis of your heart. I have another question. Between lead 1 and lead 2 and lead 3, which two leads do you think we can use to determine the electrical axis of your heart? Which two leads do you think you can use? Like imagine your heart is oriented in this particular direction, and you want to find the mean electrical axis of your heart. Which two leads do you think can be very important? Lead 1 and 2, lead 1 and 3, lead 1 and 2, lead 2 and 3, or which one do you think we can use? Amazing. Hey, Musdaf, you need to be given an Oscar award together with Violet. So because your art is basically oriented in this particular direction, look at how the art is oriented in this particular direction, where the base is here and the apex is towards lead 3. So it is actually more appropriate for you to use lead 1 and lead 2 because they are towards the direction where we have the apex of your art. You get? So we usually use lead 1 and lead 3 to determine the mean electrical axis of the art. Now, how do we do it? That's the golden question. So after running an ECG machine, you will get lead 1 ECG and lead 3 ECG. You take them. Now, in the triangle that you are drawn a circle, right, around it. Now, so let us continue. Now, after drawing that triangle that you have, you draw a circle around it, and the center of the circle is usually the geographical point of your heart. Like this, the point where you are going to put your compass to draw that circle is usually assumed to be, usually taken to be the center of your heart. Then now what you do, this one was lead 1, lead 3, and lead 2. You'll now come to lead 1 and you dissect it into 2. You now have to dissect a line into 2, right? So you dissect lead 1 and lead 2 into 2 dissection. Then now you come to your ECG. You want to be very keen here. Let me use this lead 3. This one can be a bit confusing. I don't want to use it. So assume that this lead 3 is lead 1, assuming that it's lead 1. What are you going to do? You're going to take the summation of the upward wave plus the summation of the lower wave and the lower wave. I don't know how I can put it. This diagram is a bit messy. Let me look at a good diagram. Okay. So look at this diagram that I'm projecting. Now, for you to actually construct it, what you are going to do, look at the QRS complex. So we have the R wave going up and the S wave going down. So we're going to find the geographical sum, the algebraic sum between the R wave, the Q, and the S wave. So what are you going to do? In your graph paper, or rather in that is you usually have the graph, the grid lines. You're going to count the number of small boxes from here up to here, the R wave going up. Let me show you using this diagram here. Yeah, so concentrate on this diagram. So I'm going to come on my R wave from the isoelectric line, then I count the number of boxes. 1. How many are they? I'm using lead 2. Focus on lead 2, the first one. It is 1, 2, 3, 4. Hey. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let's say there are 13. We'll take 13 plus, you go to the Q wave. You go to the Q wave. Oh, 14. Amazing, 14. So it will be 14. Then you go to the Q wave. The Q wave for this particular one is, let me say 1, right? It's around 1 or a half there. The Q wave, the Q wave, focus on the Q wave first before you go to the S wave. You have gone to the S wave. I think the Q wave is 1, right? But it's -1 because it's going down. So we'll take 14 plus -1 plus, what about the S wave? Now I think most of you are talking about the S wave. It is 4, right? So it will be plus -4. What will you get as the answer? +9, right? I hope you guys are following what you are doing because that's what you're going to do for your manual. So you'll come here. Now let us go back. Now, after dissecting this line into 2, for lead 1, you'll now come and do what? Count small, you'll actually come and, using your ruler, 9 millimeters. Then you draw a vertical line going down. Let me repeat. You take that line, dissect it into 2. Then after dissecting that line, you do whatever you have done. Then after doing that, you count, okay, is it positive or negative? +9. Yeah, it's +9. So because it is +9, we are moving towards the positive. You get, like, yes, negative and yes, positive. So because the value I've gotten is +9, you're moving towards a positive. So you'll count 9 boxes towards the positive end. So you'll actually come using your ruler for this particular, you just count 9 millimeters because one small box equals 1 millimeter. You count 1, 2, 3 up to 9, then you draw a vertical line going down. Then the same procedure, you repeat for lead 3. The same procedure you repeat for lead 3. Then after drawing it for lead 3, you also go, like, it's basically not a repetition. If you go for lead 3 and you get a positive value, then you're going, excuse me just a second. Okay, sorry for that. Sorry for that, guys. Now let me continue. So I hope you guys have followed what I've been doing for lead 1. Now we'll go and do the same thing for lead 3. Then in case you get a positive value, remember for lead 3, our positive was the left foot, our negative was the right hand. So in case you get a positive value, you'll go towards a positive going down, because you can see they are going down because it is positive. But if you get negative, you're going to go up. Get. So let me do a quick recap. After drawing this triangle and this circle, you dissect lead 1 into 2. Then you come to whatever we have done. Let me repeat it because people maybe have not gotten it. So assuming, I'm using this lead 2 here just to make it clear for all of you guys. But of course, you're supposed to be using lead 1. So you come to lead 2. You get the algebraic sum between the upper waves and the lower wave. So you come and count the number of small boxes for the R wave above the isoelectric line, which I think we had gotten to be 14, positive 14 because it is positive. Then you also take the summation of the S wave, which is 1 box -1 and 4 boxes -4. Then you get a summation of all of them. It will be 14 plus -1 plus -4. You're going to get positive 9. Now, because it is positive 9, when you come down here, you're going to move towards the positive side. That's why you're moving to this particular direction. The same thing, you come and you translate it into the lead 3. You come and dissect this line into 2. This is the midpoint. Then after getting your positive algebraic sum, if it is positive, you now go downwards because you have the positive terminal here. Now you're going down, you come and draw a vertical line up to that particular point. So where the two vertical points meet, you identify that point. And remember, I told you at the beginning that you need to identify the center of your heart. The center of your heart was the center of the cycle. So just come and you draw a line from the center of the circle where these particular lines are actually intersecting. That should give you the mean electrical axis of the heart. So that's how we actually calculate it. So for this particular patient, you can see that it's between around -30 to 90. So this patient is normal. So basically, that's how we usually calculate the mean electrical axis of the heart. So in case of any question, kindly feel free to ask your friends, or you can also reach out for me. I'll try to explain it. Okay. Now I've talked about all this stuff. Now, before we are about to finish, guys, don't worry. So the mean electrical axis of the heart is usually very important to show you the direction of flow of action potential. And I've told you that in case a patient has a left ventricular hypertrophy, the mean electrical axis of your heart is going to deviate to the left. But if a patient has right ventricular hypertrophy, it is going to deviate to the right. That's why we call it a right axis deviation. So the question then becomes, what are the different conditions that usually causes left axis deviation? The first condition is what you call aortic vascular stenosis. When your aortic valve is very narrow, what do you think is going to happen to you? The left ventricle is going to use a lot of energy to pump blood out of your heart. So because your ventricle will be struggling to pump blood out of your heart, your ventricle will undergo hypertrophy. I hope you're getting the point. We'll also have something called aortic valvular regurgitation, where blood is flowing out of the aorta towards the aorta, but because the aortic valve is leaky, blood is flowing back into the left ventricle. So by the end of the day, your left ventricle will be straining to pump blood out. So again, you can have a left ventricular hypertrophy. Then again, you have congenital conditions. Dr. Beda talked about them: tetralogy of Fallot, transmigration of the great vessels of the heart. You get, VSDs. He talked about all those conditions. So just go and look at which conditions can cause left ventricular hypertrophy. If you get one of them, it can cause LAD. What about for the RAD, right axis deviation? I've told you that you have right ventricular hypertrophy as occurs in pulmonary stenosis. You guys have been taught about tetralogy of Fallot. Tetralogy of Fallot is a congenital anomaly where number 1, we have overriding aorta. Number 2, we have right ventricular hypertrophy. Number 2, we have pulmonary stenosis. And finally, we have ventricular septal defect. That's called tetralogy of Fallot. And usually the patient usually develops a right ventricular hypertrophy. You get? So right ventricular hypertrophy can cause RAD as seen in tetralogy of Fallot. And I've told you congenital anomalies like dextrocardia can also cause extreme axis deviation. Yeah, so this is basically the connection of augmented leads. Oh, before I continue, you're about to finish in the next 10 minutes or so. So augmented leads are actually very important. And for our lab sessions, we'll only do for the standard bipolar limb leads. We don't always do for augmented. But the connection of augmented and the connection for standard bipolar limb leads are usually more or less the same. So for example, you can see that here we have AVR. R is for right, L is for left, and V is for foot. So when I talk about augmented limb lead and I say AVR, augmented limb lead AVR, I mean that we are in the right. So we say that these are usually unipolar. So we don't have a bipolar. You see, for standard bipolar limb leads, we had one lead here, then we were actually measuring the action potential or the voltage difference between the two places. But for the augmented limb leads, it's a bit different. It's a unipolar limb lead in that you only have one positive terminal or one unipolar lead, which is the positive terminal. Then the reference point is usually the point between this particular lead here, which is placed at the left hand and the left foot. At the middle there, we usually have the reference point, then we connect it to the positive terminal. So this is basically for AVR. This is for AVL, the same thing. The positive terminal is in the left hand, while the reference point is the point between the left hand and the left foot. So we're basically connecting to the left hand, and we're trying to actually find the voltage difference. That's for the AVL. The AVF, the positive is at the foot. So here you have the foot, as you can see. Here you have the foot. Then this foot is being connected to the midpoint of the right and the left hand, as you can see. So there we have the reference point. So usually we don't talk so much about the augmented limb leads for our lab sessions in second year, but I felt it was just maybe put this slide here so that you can actually get a touch of what I'm talking about. So what are you supposed to remember for your exams? AVR right hand, AVL left hand, AVF left foot. Then after that, there are unipolar limb leads. And something interesting, look at the AVR. Maybe someone can tell us in the chat box, what do you notice about the AVR ECG? Is it normal or inverted? Or you don't know? What can you comment about the AVR? Yep, it is inverted. Amazing, it is inverted. So kindly go and take your time to know why it is inverted. One of the reasons that I think Ninyanad usually tells people is because it's located near the base of the earth where we have the negativity. That's why it's more towards a negative. But I want you to go and just take your time to actually look at it from a new angle and understand why it is inverted. And I think that one will be covered well when you attend the lab session. So basically, this is the augmented limb leads. You can see that AVR is usually inverted. That's the most important thing to remember. AVR is usually inverted. Then you have AVL and you have AVF being upright. But you always have some differences in terms of the wave representation. Now, these are the chest leads, the precordial chest. This one you have seen them even in the Good Doctor. You have seen these things being connected in a patient's chest. And maybe you are wondering, oh, what is happening here? I'm not getting anything. So today we're going to talk about it. So the chest leads are usually put across your chest, and you have 6 of them from V1 to V6. So you have V1, V2, V3, V4, V5, V6. What will come in your exam is the following. You need to ensure the position where we fix this chest lead. So V1 is usually put in the 4th intercostal space to the right side of the sternum. V2 is usually placed the 4th intercostal space, the left side of the sternum. V3 is usually, let me skip V3 first. V4 is usually put at the 5th intercostal space at the midclavicular line. So just come and draw a line at the clavicle midclavicular line to the 5th intercostal space. So where they intersect is where we have the V4. So V3, sorry, is usually put between V2 and V4, sorry. V3 is put between V2 and V4. Then V5 is put in the 5th intercostal space anterior axillary line. You guys have done the brachial plexus and the axilla in human anatomy. So go to the anterior axillary line where it actually crosses the fifth intercostal space. You put your V5. Then finally, V6 is usually put at the mid axillary line, at the mid axillary line. So basically, this is how we actually fix our leads, the chest lead. I have a question. Maybe someone can comment in the chat box. Which view do you think the chest lead are viewing the heart? Which view, horizontal view or vertical view? Just look at the way they have been oriented. Is it horizontal view across the heart or it is vertical? Anyone? Amazing. It's horizontal. Thank you for that. Let me explain. Let me try to show you guys what you're talking about. Now, I hope you can see the way I projected the screen. So usually, when you want to connect the chest lead, I have V1 to V6. So V1 will be, this is the sternum, this is the right side V1, V2, V4, then V3 in between, V5 and V6. So if you're very keen, they're basically trying to view the art in this particular plane, horizontal plane. Like they're trying to look at the art horizontally, so that if I cut my heart along where I've placed my precordial disc, I can actually cut in an horizontal plane. So remember that they usually put in an horizontal plane. What about the augmented limb leads and the augmented and standard? Is it vertical or horizontal? Anyone? For the standard and the augmented? Yeah, they're usually vertical because when a patient is like this and you're fixing a lead here and the foot, so the patient is upright. Actually, you're going to look at the vertical plane. Is it going down the vertical plane? So that will come in your exam. So remember, predominantly the augmented leads and because the limb leads and even the standard, they usually view the art in a vertical plane. So the assignment I want to give you today, guys, go and actually understand the following: that V1 and V2 usually view the septum of your heart. V4 and V3 and V4, the anterior side of your heart. Let me just try to demonstrate. I think it's good to demonstrate. So see, because your heart has been oriented in this particular direction, like this is your heart, and I have my V3 and V4, they are going to view the anterior side of the heart. You see, the anterior side, because my heart is actually underlying my chest. So if I have V3 and V4, they're going to view the anterior side of the chest. But look at what I'm doing now. When I go to V5 and V6, I'm going laterally. I'm going laterally. So they more of look at the lateral side of the heart. Now, when I'm in this position, when I place my lead one again is viewing the lateral side of the heart because this is lead one. What about AVL? AVL was being fixed in the left hand. So again, AVL is viewing the lateral side of your heart. I hope you're getting what I'm talking about. It's again viewing the lateral side of the heart. So why am I talking about these things? For you to make a diagnosis, you need to have the 12 ECG. But before I continue, before we finish, we are about to finish in the next 5 minutes. These are actually the precordial chest leads. Guys, take your time, go to Ninja Nerd. It talks about the standard, the precordial chest leads. This one is a bit complex. What do you notice about these diagrams here? From V1 to V6, which wave is increasing in size? Maybe someone can comment in the chat. From V1 to V6, which wave is increasing in size? The QRS complex. In the QRS complex, we have the QR. So between V1 and V6, what can you comment about the waves? Okay, amazing. So we have the R wave. The R wave is increasing from V1 to V6. Go and listen to Ninja Nerd and get the reason. We can't start talking about them right now, guys, honestly. It's quite a lot. Which wave is decreasing from V1 to V6? Which wave? Anyone? Amazing, the S wave. The S wave is decreasing from V1 to V6. That can come in your exams. But for MCQs, you might not be told, give the reason as such, but I think it's just twice for you to get the reason. So kindly go and understand why the R wave is increasing and why the S wave is is decreasing. Now, why the RF is increasing and the SF is decreasing across. Now, let us finish. We are about to finish. This is the last thing that we're talking about for today. We have talked about V1 and V6 horizontal plane. The limb leads, we have talked about the vertical plane. Now, the V1 and V6 usually view the art at the septal region, the septal wall. So in case a patient has a problem with V1 and V6, then it should communicate to you as a practitioner that the problem is at the septum. V3, V4, we have said anterior wall, V5, V6, lateral wall, lead 1, lateral wall, lead 2, inferior wall, lead 3, inferior wall. I think right now you can actually relate what I'm talking about. Yeah, now let me finish with this. So guys, as I'm finishing, when you want to diagnose a patient, you need to use the 12 ECG. You can't use the standard bipolar limb lead alone. And that's why usually we call the 12 ECG the diagnostic ECG. Why am I saying this? You might be given a patient and the patient has anterior wall myocardial infarction. You get? And for us to view the anterior wall, we only need the precordial or the chest leads, the precordial. Are we together to that point? So you can't use the standard bipolar limb lead to tell if the patient has anterior wall myocardial infarction. You can't. And that's why you need to have all of them, because they can be telling you the different views of the art. Some of them are going to view it anteriorly, some of them posteriorly, some of them, you get the point. So we need to have all of them so that you can get the 3D dimension of your heart. In that, a patient might have anterior myocardial infarction, but the inferior wall is perfectly fine. You know, so you're going to use V3 and V4 for that particular patient to make a diagnosis. While a patient might have inferior myocardial infarction, but they don't even have lateral myocardial infarction. You get? So because of that, you need to have the leads that are going to show you what is going to happen. And that's why we need to have the 12 ECG to make a diagnosis. So for the inferior wall, we always have lead 2 and lead 1. The reason is simple. Like when you look at your heart, this, we need to agree on one thing, that because lead 3 is at your left foot, it can view the heart vertically. Like imagine this is your heart and your foot is down here. So you're going to view it, the inferior wall, you get. And again, because we also have lead 2 going like this, again, you can actually, in a way, look at the inferior wall, because there's a way the heart has been angled. You know, go and actually check the normal orientation of your heart in terms of the anterior, posterior, inferior, and the lateral surface. They're very important for the ECG. So guys, because of time, if you have any question, kindly reach to my inbox. I'll be very free to answer them, and come personally if you have any question that you need me to clarify. But I'll try to cover everything that I think is very important for your exams. So when you go to the practical, just go and be keen, learn, then do some MCQ revision on the ECG and understand them better. I've not covered everything about the ECG. ECG is very complex, but we are learning and building on concepts every day. So someone was asking about the concept to do with left ventricular hypertrophy and right ventricular. Go and refer to Guyton kindly. Guyton 14th edition. They talk about the axis deviation, and they're going to explain better how the right ventricle can lead to right axis deviation, and even why the left ventricle can lead to left axis deviation. It's about electronegativity and vectors. I won't go into it right now because it's quite complex. Yeah, so Mustafa is telling me, thank you so much, brother. Welcome, bro. We are here to help one another. The triangle is a must, but usually most of the time you'll get it in your manual. So don't draw it if it's in your manual. Just draw that circle around it and you finish it. Yeah. So I'll send the recording later on. I'll share with you guys. And thank you so much for creating time to listen to me. I'm so humbled. So humbled. So guys, have a nice afternoon and see you on Thursday and Friday in the practical.